This is Babu Dan of Beta International, and welcome to the third day of the Oxygen Therapy Seminar at Arusha Technical College in Arusha, Tanzania, conducted 14 to 16 December 2020. Our topic today is mechanical ventilators in oxygen therapy, as well as the use of oxygen analyzers on mechanical ventilators. So here's an overview of the topics we'll be discussing. We'll be discussing settings, which always include things like breathing rate and tidal volume. We'll talk about modes, which are, for instance, assist control or SIMV control, either by volume or by pressure. We'll talk about the advantages and disadvantages between the modes, guidelines in the initiation of mechanical ventilation, and common troubleshooting examples with mechanical ventilation. Now we'll start with this warning that you as a biomedical technician or engineer should never recommend settings to a clinician. That is not your job. Your job is to understand the settings and the modes so that you can test their proper operation only. There is a temptation to respond if a staff member asks you, "Where should I set the alarms?" That is not your role. So here are the goals of the training. To understand why we use mechanical ventilators, how they function, who controls the settings of the ventilators, and how do the settings change as a patient goes through recovery, what preventative maintenance is required, what are the common faults and repairs, and how do I repair, and how can I assist and understand respiratory therapists who have a very specialized and in-depth knowledge. Why use mechanical ventilators? And in particular, when do we go from a nasal cannula administration of supplemental oxygen to full-on ventilator support? Well, the patient cannot breathe enough on their own. And that means basically they can't perform the functions of inhalation and exhalation sufficiently to both inhale enough oxygen and exhaust enough carbon dioxide. The causes can be lung injury, disease, anesthesia, or CNS, central nervous system. So the central nervous system may not be working right because of a stroke or some other type of brain injury. There can be a CNS depression which stops normal lung control, and that happens, for instance, when we administer anesthesia drugs to put someone into a deep coma, or narcotic pain control in some cases, if it's extreme. So diseased lungs have less capacity for both absorption of oxygen and emission of carbon dioxide. And finally, pulse oximeter measures of blood oxygen, the lung health. And that can often be the reason that oxygen therapy is started to begin with. And I would add to that a capnograph can also be used to determine whether or not carbon dioxide is being emitted sufficiently. How do ventilators work? Ventilators use positive pressure to force breathing, more or less like inflating a balloon. Now, iron lungs, the original type of ventilator, used a vacuum, negative pressure, outside the body to expand the lungs in an artificial breathing cycle. Modern ventilators, however, push air into the lungs with positive pressure and extract it just by releasing the pressure. Now, we learned in respiration physics that the intercostal muscles have to contract in order to expand the rib cage, and the diaphragm has to contract to increase the space. But relaxing either of those will cause the lungs to return to their normal diminished size. So it's not necessary to force the lungs back into a smaller size, only to inflate them. Now, oxygen gas is often added to increase blood oxygen delivered to the patient. So you get a mix of air and oxygen delivered to the patient through the artificial ventilator breath. The interface between the ventilator and the patient is called the patient circuit. It has both an inhalation and an exhalation branch, and it's not reusable. Just for a historical perspective, we've shown the original negative pressure ventilator, the iron lung, which enclosed the patient completely, sealed their body, and the vacuum was created inside this container to expand the lungs and then contract it. Modern ventilators are far more compact. So here's a modern ventilator which uses airway pressure control to force inhalation and exhalation by means of a direction-controlled patient circuit. Now the blue hose, as you can see, that's the patient circuit. Also, you see they're going to what is a humidifier, which is often used if a patient is going to be on a ventilator for an extended period of time. They need to moisturize the breath. Now, as noted, there's an inhalation and exhalation path to the patient circuit. Here's one example of a ventilator patient Y circuit with an inhalation and exhalation branch, and there's also moisture traps. Those little blue containers are designed to capture the moisture that comes from humidifying the air and condenses inside the tube, and if it has nowhere to go, it can actually clog the tube. So the caregiver has to be vigilant and make sure those don't fill and block flow, but the ventilator will give a warning if they are. Now, one of the things you'll notice is there is a difference between this patient Y circuit and the ones we're going to be using for the lab. One of the key differences is you don't see the two small tubes that are on our patient Y circuit, which measure the inhalation and exhalation pressures and take that information back to the ventilator. So we have a couple of small tubes in addition to these inhalation and exhalation paths, which convey information back to the ventilator. Also, we have a PEEP valve on the exhalation path, which keeps the pressure after exhalation to be a positive value. We'll discuss that later. If our goal is to inflate the lungs with positive pressure, like balloons, we need an airtight path from the ventilator into the lungs. So we have the patient circuit, which goes to the Y connector from the ventilator. From the Y connector into the lungs, we have three different options. One is a tight-fitting mask, the other is a nasal tracheal tube, and then finally the more common oral endotracheal tube, which bypasses the epiglottis and makes sure that the air goes directly into the lungs and not into the esophagus. In order to place that, we use the tool we mentioned before, laryngoscope. So here's a patient Y circuit connected to a face mask. Now, face masks risk forcing air into the esophagus, especially in unconscious patients. So it's generally only used with a conscious patient. And even so, it's possible for air to be forced into the stomach and cause vomiting. That's because the epiglottis is a small flap of skin which directs the throat either to the esophagus or to the trachea, to the lungs. And in an unconscious patient, it's not always under control. So some of the most serious forms of respiratory impairment, such as ARDS, which is Advanced Respiratory Distress Syndrome, which is one of the outcomes of COVID-19 infection. There are very drastic measures that have to be taken to ensure that an unconscious and in fact paralyzed patient can receive breaths directly under the control of the ventilator. And this requires intubation with an endotracheal tube, which is positioned using a laryngoscope past the epiglottis to make sure that it goes into the lungs. And then a tight seal is achieved by inflating a balloon at the end of the endotracheal tube. Now, the way in which ARDS is treated, for instance, is to actually paralyze the patient so they cannot breathe on their own, and then to perform very low volume ventilation. We're spending a lot of time on patient circuits, but it's important to understand that there are different uses for patient circuits, and each ventilator calls for its own particular patient circuit in many cases. Here's an example of a patient circuit used in anesthesia machine with a ventilator bag. This is basically a constant volume ventilator, and because the patient is deeply sedated and the ventilation actually takes over their breathing. You see there's an inspiratory and expiratory valve. It forces the direction of the breathing. And one of the differences in anesthesia with the patient circuit is it's a closed system where you're trying to recapture anesthesia gas and filter out carbon dioxide. So it's quite different than long-term ventilation for respiratory therapy needs. Here's an example of a patient circuit with a humidifier inserted for when the patient is on extended therapy and the inhalation breaths need to be moisturized. There's actually a heated wire in the inhalation branch which prevents excessive condensation and also ensures that the breath that the patient is receiving has been controlled to exactly 37 degrees centigrade body temperature. And this, it diminishes any shock for the body at receiving cold air, for instance. So here's a flow diagram for the patient circuit with a humidifier. It shows the heated wires and the inspiratory branch, which help keep condensation from happening there and keep the temperature right at body temperature, which minimizes the shock to the patient. One of the things that's very important to realize, if you're going to use an oxygen analyzer to measure the oxygen delivered at the patient Y, which you would if you were calibrating, for instance, the oxygen saturation control of a ventilator, you want to make sure that the humidifier is not there. You do not want moist air going into an oxygen analyzer. In a chemical analyzer, you can actually damage the analyzer itself. In the wind power ultrasonic one, it won't damage the chamber, but it will introduce moisture, which will have to be dried out, and it will also give you an incorrect reading. And it's equally important to realize that if you have a humidifier on an oxygen concentrator, you do not want any moisture introduced before you're measuring the oxygen output of that oxygen concentrator. So here's a typical ventilator control schematic where a compressor is controlled to produce controlled flow and pressure. And it's a little different than our transport ventilators because the Pulmonetics version actually uses turbines, controlled speed turbines, to generate the inhalation path. And that actually adds a much finer degree of flow control and pressure by controlling the speed of a turbine. But the basic idea here is that you have feedback of temperature, pressure, and flow from the patient circuit, which gives the control circuit or microcontroller the knowledge of how to control the compressor or turbine. Who controls ventilator settings? First of all, it's not you as a biomedical technician, no matter who asks you to do it. Respiratory therapists control therapeutic ventilator use, while anesthesiologists may control them during anesthesia and surgery. Respiratory therapy requires that sick patients eventually regain full function of their lungs. So it is best to wean them off a ventilator by allowing them to assist the ventilator and regain muscle control. RTs do this. Anesthesia requires the ventilator to completely take over the job of breathing while the surgery is performed, but only while the patient is under sedation. And this tends to be a short-term procedure. The ventilator is not responsive in any way to the patient. It simply takes over the entire task. Much of the complexity of ventilators has to do with the respiratory therapy use, where they allow the patient to control their breathing as much as possible. What happens during anesthesia? Heavy sedation slows or stops response of the brain to pain, so the muscles don't react during surgery, and this can also cause the lungs to stop functioning. So ventilators replace the brain's control of the lungs during unconscious sedation and ensure that pulse oximeter sensors show adequate blood oxygen. Capnographs are also used to monitor carbon dioxide in exhalation. Ventilator modes are simple during anesthesia, usually taking total control of breathing, usually volume control. Always there is a bag which can be used to manually inflate the lungs if the ventilator should fail during surgery. Anesthesia gas is added to the patient circuit only when the oxygen sensor detects that enough oxygen gas is also being added. There's usually an physical interlock between those two as well. However, oxygen cannot be measured in an anesthesia machine with your wind power oxygen analyzer because it is designed as a two-gas oxygen sensor only. It will not operate reliably in a mixture of gases. So what happens during respiratory therapy as opposed to ventilation during anesthesia? Ventilators may initially be used to keep a patient breathing during treatment for disease or physical trauma. But the RT's recovery goal is to get the patient back to normal breathing on their own, which involves complex ventilator control, giving the patient more and more control over their breath. So pressure, air, and volume and flow rate are all measured by sensors and can be controlled in different modes of ventilation. The biomedical technician must understand the modes well enough to know which sensors or valves may be affecting operation if a respiratory therapist complains of malfunction. Respiratory therapy involves a great many more modes of ventilator operation, each chosen to best treat a disease or injury for the quickest recovery and minimize intercostal muscular atrophy, which happens when the machine takes over breathing. It's important to realize that modern, newer ventilators are so intelligent, it is very difficult to test their function. Usually they have self-tests, but they can be monitoring and making decisions on so many different parameters that it's virtually impossible to do anything other than simply changing filters. However, for many of the ventilators, especially transport ventilators, which you are dealing with, their functions are far more limited. So what happens during respiratory therapy as opposed to ventilation during anesthesia? Ventilators may initially be used to keep a patient breathing during treatment for disease or physical trauma. But the RT's recovery goal is to get the patient back to normal breathing on their own, which involves complex ventilator control, giving the patient more and more control over their breath. So pressure, air, and volume and flow rate are all measured by sensors and can be controlled in different modes of ventilation. The biomedical technician must understand the modes well enough to know which sensors or valves may be affecting operation if a respiratory therapist complains of malfunction. Respiratory therapy involves a great many more modes of ventilator operation, each chosen to best treat a disease or injury for the quickest recovery and minimize intercostal muscular atrophy, which happens when the machine takes over breathing. It's important to realize that modern, newer ventilators are so intelligent, it is very difficult to test their function. Usually they have self-tests, but they can be monitoring and making decisions on so many different parameters that it's virtually impossible to do anything other than simply changing filters. However, for many of the ventilators, especially transport ventilators, which you are dealing with, their functions are far more limited.